Well, good afternoon. I'm Tim Weidrich, Section Chief of the Health Resources Response Section with the North Dakota Department of Health, and welcome to this press conference by the North Dakota Department of Health. Today we're going to have a number of individuals speaking with us, including Dr. Carson, who's an infectious disease physician, the manager of the immunization program, Molly Howell, and Dr. Mason, the director of our state laboratory. And the last time we were gathered in this room was last March, when we held a press conference from this area, so welcome back. If you've been watching the numbers from this past week, you'll probably have noticed that the numbers for positive cases have seemed to steadily decline during this past week, which is obviously good news. The bad news, unfortunately, is that the rates of hospitalizations and deaths of people with COVID in North Dakota did not follow that same trend. And so while we're encouraged by the direction that the level of positive rates appear to be taking, our work is far from done. And everyone in the state has a role to play in that work. The reason that it's so important for us to do the work that's necessary is because it does have a direct impact on the number of people that are being hospitalized in our healthcare facilities, and the impact that that's having on the healthcare professionals within the state that are doing incredible work under very stressful conditions, and the impact that this disease is having on the family of those that have become severely ill or have passed is profound. And so that work that I'm talking about really does involve some significant changes that many of you made this past Thanksgiving. So thank you to all the families that modified their travel plans or their gathering plans for this past Thanksgiving by reducing the size of the gatherings. And that process that we're talking about needs to continue now as we look forward to the upcoming holidays. Obviously, these are extraordinary times, and the holidays that are coming towards us will need to be dealt with in a different manner than what we're normally doing those holidays. And so we're recommending that you plan those activities to include things like a virtual party, to shop locally online rather than going into stores, to obviously do the things that have been talked about repeatedly, wearing face masks and maintaining physical distances. Washing hands, sanitizing frequently, and especially if you've touched surfaces that are being touched by others. And then obviously, again, stay home when you're sick. These all have a profound impact on the rest of society and our most vulnerable populations in long-term care facilities and within the hospital rates as well. We have an opportunity to have some conversation right now with Dr. Paul Carson. Dr. Carson is a well-known subject matter expert. He's an infectious disease control physician. He has a role as a professor with the Department of Public Health at NDSU. He's also the director of the NDSU Center for Research, Immunization, and Education. And Dr. Carson is going to join us now by telephone. Dr. Carson?
Good afternoon, Tim, and good afternoon, everyone, and thank you for having me. As Tim just so aptly outlined, we've really had a lot of struggles and sacrifices and suffered greatly under this pandemic, but we really have, I think, some reasons to be optimistic and hopefully be seeing some light at the end of the tunnel. We've got great news of 2 vaccines that are likely to receive what we call emergency use authorization in the very near future, and probably will be distributed to the states very soon. This is the Pfizer and the Moderna vaccine that most of us have been hearing about. And what's striking about both of these is that they've displayed about a 95% efficacy, which means they will prevent a person from getting the infection up to 95% of the time. One of the vaccines had a little bit more data in their early press release that reported that the level of protection was seen essentially in all age groups, including those over the age of 65, which is very good news because oftentimes vaccines may not have as good of uptake as we get older. Furthermore, both the vaccines actually showed excellent protection against the more severe form of COVID disease. So this level of protection would actually put these vaccines, if this holds out to be true on the further, extensive review, this would put these vaccines among the very best vaccines we currently have in our armamentarium. The other exciting thing about these is that neither, thus far, have shown any major safety concerns. And both of them are wrapping up what the FDA required, which was a minimum 2-month post-vaccination safety review process after the closure of the trials. We know from many, many other vaccine trials that we will typically find well over 90% of any serious complications of a vaccine within about 6 weeks after the closure of vaccine studies, and we will have 8 weeks of data to review. And in addition, we will have ongoing safety review of these vaccines as they are rolled out and used. The Pfizer vaccine will have its emergency use authorization review on December 10th. The Moderna vaccine will have its emergency use authorization on December 17th. Now, some of the questions that come up about these vaccines are the speed with which they've been developed. The name, Operation Warp Speed, I think meant to instill optimism, may have actually instilled a little bit of concern about have they come out too fast. And I really want to assure people that the reduced time frame was a remarkable feat that actually did not shortchange the key components of the FDA regulatory approval process that assures that a vaccine has to achieve a very high bar of safety. The FDA has this well-outlined regulatory process for any licensed vaccine, even with an emergency use authorization, that the pharmaceutical companies have to go through, which is a rigorous process that meets a standard for safety and efficacy before they will be released. All of the COVID-19 vaccine candidates being studied in the U.S. are in the process of completing these several phases of human studies to assure their safety and efficacy. What has been significantly shortened, and what is the, quotes, warp speed of all of this, is the production process. Because normally a pharmaceutical company will not start making until they've gone through the full regulatory process and received full approval. They do not want to make that investment. The federal government decided to take a bit of a gamble, and they funded the production of what they thought were the leading vaccine candidates at the same time that they were undergoing the studies, so that if they proved to be safe and effective, they would be ready to roll out. And that's essentially what has happened. So these vaccines have been in production along the way that they've been being studied and are essentially ready to ship should they get that final approval as expected on December 10th and December 17th. What is an emergency use authorization? Well, it's likely that the COVID-19 vaccines will be made available under what is called an emergency use authorization provision, or EUA, from the Food and Drug Administration. And what an EUA allows is that it enables the use of unapproved medical products or unapproved uses of already approved products but for not that particular purpose to diagnose, treat, or prevent serious life-threatening diseases when certain criteria are met, one of which is that there's a federally declared emergency and that there are no other adequate approved or available alternative treatments or vaccines or preventatives. So the FDA must determine, among other things, that the known and potential benefits of the product outweigh any known or potential risks. So we are in that federally declared emergency, and a full FDA approval would take typically a year or more for them to review. What the FDA has done is they've done a rolling review as each of the phases of this study has been going on. So they've expedited the review process, and as I mentioned already, they've expedited the production process. Waiting for the full FDA approval process would most certainly mean thousands of more people being hospitalized, tens of thousands or more being, thousands of people dying, tens of thousands being hospitalized from COVID-19 if we were to wait for that full FDA approval. And that's why this emergency use authorization is so important. The FDA has established very strict safety and efficacy criteria in order for the vaccine to be approved. That criteria, as I had mentioned earlier, requires 2 months of post-vaccination safety data. They said they set minimal clinical trial sizes, which were tens of thousands of study subjects. Actually, the study trial sizes were larger than most of the trials we've had in the past for other vaccines. They also set the bar that we had to have at least 50% effectiveness of any candidate vaccines and needed to see a certain number of infections and severe COVID cases in participants to be able to judge whether or not the vaccine was working. And to everyone's surprise, they far exceeded that 50% bar with this 95% efficacy rate. Also, these COVID-19 vaccines are being reviewed exhaustively by external and independent experts. Because vaccines are typically given to millions of healthy individuals, we actually set the requirements much higher than we would for things like medications that might receive an emergency use authorization because those are used to treat sick people. Vaccines are given to typically healthy people. So we actually have a higher bar for safety and efficacy than we would for a drug or a treatment. The committee, the independent committee that is going to review this is called the Vaccine and Related Biologic Products Advisory Committee. Short abbreviation for that is the VRBAC. And this is a group of independent experts and scientists that are outside of the pharmaceutical company, outside the formal FDA, and they will advise then the FDA on recommendations for approval. Then the review and recommendations are overseen by a second independent committee, what's called the Advisory Committee on Immunization Practices within the CDC. Now, these vaccines have been reported to have some side effects. Both vaccines have been noted to cause some short-term side effects like fever, headache, fatigue, a sore arm. This is probably a little bit more than we might see, for example, with the typical flu shot. This happens a little bit more often after the second dose of the vaccine. Both of these candidate vaccines have two doses, either 3 or 4 weeks apart. But these side effects are fairly minimal. Most of them only last a day or two. And they're really an indication that the immune system is working and responding to the components of the vaccine. You're making an immune response, and that's why we get this little bit of inflammation in the arm or in the body. And again, that's been mostly mild and only lasting a day or two. And so far, we've had no major serious adverse events seen with either of these vaccines. The other thing that I think it's really important for people to look at with all of this is risk on both sides of the equation. People, wonder about, well, are these vaccines safe? And quite honestly, with the data that we were likely to have in hand, any serious adverse events would have to be in the 1 out of like hundreds of thousands to smaller to have kind of gotten through those trials. And we have to weigh that against the actual risk of the disease. Without a vaccine, there is really every reason to expect that the virus will continue to work its way through our communities, through our population, until it's infected probably most of us over the next several months. This would mean thousands of more North Dakotans hospitalized and hundreds of more deaths. A vaccine, quite honestly, is the only reasonable way out of this pandemic. And so choosing not to be vaccinated means choosing to likely get COVID-19 in the future as this pandemic continues to march through the population. So I personally look at this and plan to get it. I will get it as soon as the health department deems me eligible in one of the eligible groups. I will be strongly encouraging all of my family and friends to get the vaccine. And by doing that, we not only protect ourselves, but we become essentially a sort of a blocker or a shield to those around us who we care about and love. So I would encourage every one of us in North Dakota who, when we may be eligible to receive these vaccines pending their approval. And I'll turn it over to Molly to discuss a bit more about the vaccine distribution plan.
Thank you, Dr. Carson. Hi, everyone. Thank you for being here today. I am going to talk about how COVID-19 vaccine, when available, will be distributed in North Dakota. As Dr. Carson mentioned, we have a couple of vaccines that will likely be available in the near future. The FDA's advisory committee will meet December 10th to discuss the Pfizer vaccine. And if recommended for use in the United States, that vaccine could ship as soon as 24 hours after that meeting. The Advisory Committee on Immunization Practices that Dr. Carson mentioned, this is an independent committee that makes recommendations for how vaccines should be used in the United States. It will also make recommendations for how vaccines should be prioritized. They'll meet within 24 to 48 hours of that FDA VRBPAC meeting to discuss who should receive the vaccine and recommendations for the vaccine. And then the CDC takes the ACIP recommendations and publishes them within 24 hours of that. And so really, vaccine will likely be in North Dakota the week of December 14th, and providers will start administering it once they're educated on all of the recommendations and how the vaccine should be administered and used. The Moderna vaccine, that FDA Advisory Committee meeting is scheduled for December 17th, and so likely that vaccine would first ship the week of December 20th. I do want to mention, as some of you remember, North Dakota was previously selected as a pilot planning site for COVID-19 vaccine. We were one of 4 states selected, and CDC was here, and we started planning for distribution of COVID vaccine. That does not mean North Dakota is receiving vaccine before any other states. We are receiving vaccine at the exact same time as everyone else in the United States. I do want to say that the vaccines, although they are coming, they are going to be extremely, extremely limited in the very beginning and initial phases of vaccination. And so people will have to be patient, waiting till their turn comes up in order to receive vaccine. So for example, we're anticipating when the Pfizer vaccine becomes available, North Dakota will only be allocated 6,825 doses. And then the week after, when the Moderna vaccine is available, we'll likely receive 13,000 doses of that vaccine. And then each week, states will be allocated doses. We're not sure quite yet how many doses it will be each week. It will depend on the manufacturing, and those doses will be allocated by the federal government. So because we have such limited doses, vaccine will be prioritized for certain groups of individuals. The ACIP, or the Advisory Committee on Immunization Practices, is a national group that makes recommendations for vaccines that are routinely used in the United States. They will also be making recommendations for COVID-19 vaccine. And so they actually did meet yesterday. I know there was a lot of media around their meeting to discuss phase 1A of vaccination. And so these are the first people that should receive COVID-19 vaccine. And that is healthcare workers and long-term care residents will be in phase 1A. And then it's likely there will be subsequent phases where potentially critical infrastructure like police, fire, teachers, child care workers would be vaccinated. Another group of people that will be high priority are people 65 and older who aren't living in long-term care settings. And then also others at high risk, so whether they have an underlying health condition like diabetes that puts them at high risk, or if they live in another type of congregate setting like corrections or homeless shelters. So to put it into perspective for phase 1A, which again is healthcare workers and long-term care residents, there are almost 70,000 healthcare workers in North Dakota and about 12,000 people living in long-term cares. And so for the first week's allocation, we'll have 6,825 doses to divvy up. And so because we don't have enough vaccine to give to everyone for phase 1A, we have established a North Dakota Advisory Committee on COVID vaccination ethics. This is a group made up of 5 people who have volunteered to advise Unified Command and the Governor's Office regarding ethical distribution of COVID-19 vaccine in the state. It's made up of 5 members, a physician, an ethicist, a local public health representative, a representative from the Department of Human Services, and a representative from the Department of Health. The committee is facilitated by Dr. Stephen Pickard, a retired medical epidemiologist and advisor to the Division of Immunizations. They have been this entire time working on creating priorities for Phase 1A and have come up with tiers within the phases for orders of vaccination, and those are posted on our website. They were posted today. And so Tier 1A of Phase 1A, just to confuse everyone, is frontline healthcare workers at referral hospitals. And so the first doses that North Dakota receives will be first going to the referral hospitals in the hopes to stabilize our healthcare workforce and to make sure that they're able to care for patients across the state. Also in Tier 1A are critical access hospitals and providers with direct patient contact, and then other healthcare workers in the community like EMS, emergency medical services, and local public health that will be giving a lot of these vaccines and is doing a lot of the COVID vaccine testing across the state. In Tier 1B is long-term care residents and staff. And so it's very likely that we'll move very quickly through these phases. And so the first week will likely just be the referral hospitals, but we expect to get to long-term care before the end of this year. I also want to mention for the long-term cares and how they will be vaccinated, the federal government has stood up a federal pharmacy partnership program where they contracted with CVS and Walgreens to vaccinate long-term cares who wish to be vaccinated by this program. North Dakota does not have any vaccinating Walgreens. We do have 6 CVS's. And because we had such limited number of chain pharmacies, they've also included Thrifty White in this program. And so about 80 long-term cares in this state will be vaccinated through this program by either Thrifty White or CVS. Other long-term cares have chosen to go with an independent pharmacy that they normally use or local public health or just give vaccines on their own. As Dr. Carson mentioned, both of these vaccines require 2 doses. The Pfizer vaccine is 2 doses 3 weeks apart. Moderna is 2 doses 4 weeks apart. People should receive both doses in order to be protected against COVID-19. And so when you're vaccinated, people will receive a vaccine record card that's being supplied by the federal government. We're encouraging people to keep that card so they have a record of when they were vaccinated and even take a picture of it with your smartphone. Additionally, all doses will be put in the North Dakota Immunization Information System, so there will be a permanent record of everyone's vaccinations in that system. I do want to mention that this is going to look a lot different than our traditional flu season or other vaccines that we routinely give, and a lot of that is because of the storage and handling of these vaccines. The Pfizer vaccine requires ultra-cold freezer storage down to negative 70 degrees Celsius. Most providers in the state do not have that type of storage. And so some of the options are it can be kept in its shipping container, and then dry ice can be replenished if providers want to use the shipping container, and that shipping container can be used for 15 days. Otherwise, we do have a state warehouse that will be able to break down that shipment into smaller quantities and supply it to providers across the state. That vaccine does ship in quantities of 975 doses. And so in order to get it to rural areas, it will likely have to be broken down. And then it is stable in the refrigerator for 5 days. And so the doses do have to be used within that 5-day time period or discarded. The Moderna vaccine requires frozen storage, which many providers do have. There's other vaccines like the chickenpox vaccine that requires frozen storage. And it will likely have refrigerator stable temps for 30 days when it's EUA approved. And that one ships in minimum quantities of 100 doses. But if needed, our state warehouse can also break down that vaccine into smaller quantities for our rural areas. So I know a lot of people are wondering when it's their turn to get vaccinated, and we will definitely be letting people know. We'll be at press conferences like this. We'll post on social media, on our website. All of the phases will probably have tiers so the public will know when they might be up for vaccination. I just want to encourage everyone to be patient, and if you're not in one of the high-risk groups, it's probably not going to be until next spring or summer that you'll have access to the vaccine, and that's really dependent on if we have additional vaccines approved. There are other vaccines in the pipeline, and also the manufacturing process for this vaccine. When the vaccines are first available, pregnant women and children will likely not be able to be vaccinated as they were not, at the time, participating in the clinical trials. The vaccines will be available from a number of pharmacies, private healthcare providers, local public health. We'll be posting to vaccinefinder.org availability of COVID vaccine once it does become publicly available. It will be provided at no cost. The federal government is fully funding this vaccine, and so there will be no cost for the vaccine. Healthcare providers can charge a small administration fee and bill insurance, but if your insurance for some reason doesn't cover it, or which most of them will, or if you're unable to pay that admin fee or don't have insurance, you cannot be turned away for inability to pay. I just really want to say that this vaccine is really needed to achieve community immunity, or what's known as herd immunity. We're hoping for a 70% vaccination rate. That's what experts say is needed in order to stop transmission of this virus in the community. But until we get there, people need to still take precautions like wearing masks, social distancing. If you're exposed, you should still quarantine in order to prevent the disease, and we all have to do this together until we can all be vaccinated. And now that I've talked about COVID-19 vaccine, I also have to put a plug in for routine immunizations, because during the pandemic, we have seen declines in immunization coverage rates amongst children and adults for routine immunizations. According to the North Dakota Immunization Information System, 8.3% less doses were administered in 2020 when compared to the same time last year. There have been measles cases that have traveled through airports like Seattle and Chicago, and we don't want to see measles outbreaks on top of COVID-19. Adults still need to receive flu vaccine, zoster, shingles vaccine, pneumococcal vaccines. And it isn't too late to get your flu shot, and so we want to make sure everyone is still vaccinated against influenza. We've already reported 86 influenza cases this year, but the flu generally doesn't peak until February or March, and so there's still definitely time to be vaccinated. And for more information about vaccines or COVID-19 vaccine, we just encourage everyone to go to our website for more information, and make sure you're getting your information from reputable sources like CDC, like the American Academy of Family Physicians, infectious disease experts, or the North Dakota Department of Health. And specifically, I want people to go to our COVID vaccine website and look at our Q&A. We have a Q&A that answers a lot of questions that people might have about COVID-19 vaccine, like how long does immunity last, and things like that. So I encourage you to go to our website to find out more information about that. So now I'm going to transition to another topic. I'm going to talk about CDC's quarantine changes that I'm sure many of you saw in the media today. Overall, and I think we've all experienced as the pandemic has gone on, we've constantly learned more and more about COVID-19. And so as that's happening, public health experts like the CDC are looking at data and making changes based on new information that becomes available. And so today, CDC announced that they are changing the quarantine period, which historically has been 14 days from the last time you were exposed, down to 10 days. And that's because they have data showing there's a much smaller chance of transmission of the virus after that 10-day time period. And so the new guidelines for close contacts to people who have tested positive for COVID are that the quarantine period can be reduced from 14 days down to 10 full days. And then if someone is tested, they can potentially reduce their quarantine down to 7 full days. And so in order to use the 7 days, they have to have a negative either PCR or antigen test within 48 hours of ending their 7-day quarantine. And so while they're waiting for their test results, they do still have to wear a mask and stay home and stay quarantined. And regardless if their time period ends at the 7 days or the 10 days, they should still wear a mask and monitor themselves for symptoms for the full 14 days that they had previously. It's a little different for household contacts because they're continuously exposed to the individual in the household who's a case. And so if you're a household contact and you can't separate from the positive person in your household, your quarantine period does not start until their 10-day isolation period is over. And so the case would have to be isolated 10 days, and then you would start your quarantine period, which could be 7 or 10 days after that. And so individuals who are currently quarantined in the state of North Dakota can start this immediately. And so if you're on day 11, yay, you get to get out of quarantine right now. If you're on day 6, you might want to go out and get a test to see if you can be released from quarantine early before the 10-day time period. But otherwise, just so everyone knows, it's 10 days. Unless you receive a test within 48 hours, then it can be 7 days. And so I hope I didn't thoroughly confuse everyone. We will be updating all of our guidance on our website, all of our fact sheets, our survey that we have that advises people on their quarantine periods. So this just happened today, so go to our website for more information on that. I also wanted to mention, Tim was talking about the holiday season, looking forward to the winter holidays. CDC has advised postponing any holiday travel and staying home. If people do choose to travel, they should consider receiving a test 1 to 3 days prior to their travel. And then once they arrive back at home after traveling, they are recommended to receive a test 3 to 5 days after returning home. And then they should also try and reduce any non-essential activities for 7 days after returning from travel. And if you don't get tested, people should try and reduce any non-essential activities for 10 days is the recommendation. And so get tested before, get tested after. Even if you test negative, all of these tests just show whether or not you're positive or negative that day, and so you still need to take precautions throughout your trip. But ideally, we're hoping people will stay home this year in an effort to try and prevent the spread of COVID-19. And so now I'm going to turn it over to Dr. Christy Mason, our lab director, for some updates on lab testing.
Thank you, Molly. Good afternoon, everyone. I'm here to just give you a quick update about what's happening down at the State Public Health Lab. North Dakotans have actually taken over 1 million tests already throughout this pandemic, which is really exciting to see. And it's a very exciting day down in the lab today because the 800,000th test is actually being processed in our lab today. So we've come a long way from our very quiet lab that was doing 200 tests a day to doing up to 7,500 tests a day. So big shout out to everyone who's working down in the lab, all of the support team members down there. You're doing a fantastic job so that we can help identify those that are positive for the virus and get them isolated and help reduce the spread of this disease. So very exciting. In addition to just the number of tests that we're able to do at the lab, we're really having a successful month back in November with our turnaround time. And so 97% of the tests that we performed in the month of November were actually reported in less than 36 hours. And the vast majority of those, 71%, were reported in less than 24 hours. So not only are we testing a lot, we're doing a really great job of getting it turned around. And again, this couldn't be done without our great laboratorians and the laboratory staff that's helping us accomplish that. bringing us up to that 7,500 daily test capacity was accomplished by adding our new Thermo Fisher Amplitude robotic system. It's the Thermo Fisher system that's a PCR mechanism that allows us to maneuver a lot of tests with the decreased amount of staff, which is really helpful. Currently, the laboratorians are using that instrument to perform around 3,000 tests a day, and as we get more trained staff and become more familiar with that brand new piece of equipment, we are able to do up to 6,000 tests just on that one instrument alone, which is really exciting. And just a few months ago, that was just a drawing on a napkin. So we had, I think, the fourth one, is that correct? Yeah, the fourth instrument in the nation, so that's really exciting to have that here in our lab. By expanding and constantly working to increase how many tests we're performing in the lab, we're helping identify more cases, and as we identify them quickly, we're able to get them in quarantine and isolation faster so that we can hopefully reduce the spread of the disease. And while molecular tests like PCR remain the gold standard for the detection of the virus that causes COVID-19, we're very excited about increasing our capacity using a rapid test. The Binax test is a great tool to have, and it can help supplement PCR testing. PCR tests typically take a couple of days to perform. You have to get it to a high throughput, high complexity laboratory for them to process. It can take a couple of days. But the rapid antigen test is a point of care test that's done right away, right after the specimen is collected, and usually have a result in about 15 minutes. We're working to expand where those Binax tests are being used. Right now, they're working on strategies around the K-12 system, healthcare and long-term care facilities. And by doing that, it helps position us in a way that more tests are being completed every day, and it helps take a little bit of the burden off of the laboratory for some of those particular situations, which helps increase our capacity for other testing needs. But the one thing that is important to remember about those Binax tests or any of these rapid antigen tests is that they are less sensitive than PCR. So if you are asymptomatic and you have a rapid antigen test completed and you test negative, it's still really important to follow up and confirm that result with a more sensitive PCR test. And also remember that COVID-19 testing isn't a substitute for the basic measures to prevent the spread of COVID-19, such as physical distancing, wearing a mask, washing your hands, and using sanitizer frequently. So it's still important to follow all of those preventative measures and to get vaccinated in addition to getting tested. And that is all I have for you today. I will be available for questions if Tim wants to come up and moderate a question and answer session for us.
Thank you, Dr. Mason. Well, let's go ahead and open it up for questions and see who has the first one, and let's go to you, Jacob.
I'd like to start with Molly, actually. Molly, for the past few months, you've noted kind of a slowdown to people getting their vaccinations on other diseases for one reason or another. How confident are we that we'll get North Dakotans to that 70% mark that you noted?
Well, I think my confidence is growing. So I'm sure you've seen national polls, and I know there's been some North Dakota-specific polls. I think early on in the spring, polls were higher, showing more people open to vaccination, and then throughout the summer, they slowly declined. But I think the latest Gallup poll showed 58% of Americans wanting COVID vaccination, and that was prior to the efficacy data on the two vaccines being released. And so I think with the efficacy data and the safety results, I do think North Dakotans are going to feel more comfortable being vaccinated. And in general, in North Dakota, we're very accepting of vaccines. We don't have a lot of people that refuse vaccination in North Dakota. And I think especially certain groups that are at high risk, like the elderly or people with underlying health conditions or people that are essential workers and having to go into workplaces and be in close contact with others, they're going to be likely to be vaccinated. I also think it's good healthcare workers are going first, and they can set the example for other North Dakotans to accept the vaccine.
Thank you. Forum?
Hi, I'm Sam Nelson with the Bismarck Tribune. My question's also for Molly. Some of the concerns about vaccine distribution have been with the smaller clinics in more rural areas within the state. How confident is the state that it can effectively distribute the right amount of vaccines to these smaller healthcare facilities without wasting vaccine?
I think we're very confident, and I think North Dakota's in probably a better position than other states to distribute to rural areas, and that's because we do have a state warehouse. We have ultra cold chain storage equipment where we can store doses until providers are ready to receive them. We have ultra cold chain shippers, so we can transport the vaccine around the state if we need to break it down into smaller quantities. You know, the 975 minimum shipment for the Pfizer vaccine would have been really difficult to get to rural areas. And so I think because we have a warehouse that's able to break it down, we will be able to get vaccine to the rural areas, and so that it won't go to waste. We'll give them what they need for whichever population they're currently vaccinating. We also have experience doing this. During the H1N1 pandemic in 2009, we often had to redistribute the flu vaccine into smaller quantities. Are there more for me? Because then I can just go ahead.
Adam Willis with the Fargo Forum. Just speaking to some of the logistical challenges of distributing the vaccine, what do you see as the biggest challenge or the biggest few challenges in terms of making sure that everyone is immunized by the spring?
Yeah, it will be logistically challenging. I do think the biggest challenge is not knowing our allocations ahead of time. It makes it really difficult to plan, and so my understanding is each week we'll know the following week's allocation, and so that will be a short time period for when we can tell providers how many doses they're going to be receiving, and so that they can plan and get people registered for clinics. I think a lot of this is going to have to be pre-registration for clinics because there is a limited refrigerator stability, and so you have to give the doses in 5 days. So you need to know how many people are going to be coming to your facility in that 5-day time period to be vaccinated. We also don't want to send more doses to a facility than what their uptake is going to be. And so, for instance, in a long-term care, if their uptake amongst staff is only 80% instead of 100%, we don't want to send them doses for 100% of staff and then see those doses go to waste. And so I think pre-registration for clinics will be key. But I do think because we are able to redistribute the vaccine in smaller quantities, we're hoping to have a lot less wastage.
Just quickly, is pre-registering clinics already part of that protocol, or is that an option being considered?
The pre-registration is something that we're encouraging providers to do, and so I do know for the phase 1A, for healthcare workers, a lot of the health systems and hospitals have already surveyed their staff as to how many people they think would accept the vaccine. We can't really get consent yet because we need the emergency use authorization fact sheet for the vaccines, which won't be available until that EUA is approved, and that's a document that has to be provided to everyone prior to being vaccinated so they can make informed consent about the vaccine. Go ahead.
Thomas Simon, Williston Trending Topics. Are nursing homes in North Dakota ready to receive and administer the vaccines, and what training is DOH providing nursing home staff?
So for nursing homes and other long-term cares across the state, a lot of them will not be administering the vaccine themselves. They're going to be vaccinated by a pharmacy or public health. And so a lot of them will not be actually doing those vaccinations, but anyone who will be giving COVID-19 vaccine and enrolled as a provider with the state health department to receive COVID-19 vaccine had to participate in trainings about the vaccine, in trainings about how to prevent vaccine administration errors. And as soon as the vaccine is approved for emergency use authorization, we'll be doing additional training for anyone who will be administering the vaccine.
Lane Higgins, KX News. Can you clarify what a referral hospital is? Is that just your typical Sanford and CHI?
Yeah, sure. Sorry. The referral hospitals are the 4 main cities, the health systems in the 4 main cities that are caring for the most COVID patients or have those ICUs and caring for the most critically ill. And so those are the hospitals that a lot of our critical access hospitals or hospitals in the region refer their patients to for kind of that more critical care. Any other questions for me? Or I know Dr. Carson might still be on the phone too, so. No? Oh, go ahead.
I don't know if this is a question for you or for Dr. Carson. The 3-week to 4-week gap between vaccinations or between doses seems like that could be logistically challenging down the line when you're vaccinating people outside of long-term care facilities or hospitals. Do you foresee that being a challenge, or are there plans in place for how to make sure that people get that second dose on time?
Yes. So the Pfizer vaccine is 2 doses, 3 weeks apart. The Moderna vaccine is 2 doses, 4 weeks apart. And yes, it will be logistically challenging to get people in. First, they need to get back for their second dose as close to that interval as possible. So we have advised providers to schedule second doses at the time an individual receives their first dose. There is a program called V-Safe that the federal government is standing up, and it's going to be used for vaccine safety monitoring using your smartphone. It will also provide reminders for second doses, and so people can sign up for reminders. They'll also be able to sign up for reminders through the State Department of Health. The North Dakota Immunization Information System does have reminder recall functionality. We'll be able to recall people for second doses either through text or calling them or mailing them a reminder. We do reminder recall in the immunization program pretty often for routine immunizations. So.
Thank you, Molly, and we can bring Molly back to the microphone if there are additional questions coming up. I did also want to remind you that Dr. Carson is available online for additional questions as well. Other questions? Online, please.
I'm not sure who might comment on this, but Gene Shemp, Hometown Radio Group in Minot and Bottineau. Ward County has more COVID deaths than any other county in the state and almost triple the deaths of Grand Forks County despite having a similar population. Is there an explanation as to why there are so few deaths in Grand Forks and so many in Ward when their populations are about the same? And if not, is the state health department planning to look into why there is such a high death rate in Ward County compared to our other large counties?
So let me first of all see if Dr. Carson wants to weigh in on that question.
I can try, or I can make a conjecture or guess. So the death rates, you have to look at a couple of different factors. One is who's being tested. And so if you, for example, in Grand Forks, where you have large numbers of college students being tested regularly as part of UND's offering, you're testing a much healthier population, whereas in Ward County, it may be mostly people who are sick going in to be tested. The other thing that makes a big difference in this is if a lot of the cases were associated with a nursing home outbreak. And I don't know about Ward County in particular. I suspect that that's the case. But if you have a significant percentage of your cases occurring in long-term care, that will skew the deaths to be much higher, obviously in that group that's a lot more vulnerable.
Thank you, Dr. Carson. Next question, please. Dr. Mason will add additional comment.
So one of the things that we can actually look at in this state lab that we're hoping to move towards is we have actually incorporated a technology called whole genome sequencing. So instead of looking at just specifically for a target to tell us if the virus is present or not, we can actually look at the entire genetic makeup of a virus from a person. And we're hoping that by doing that and taking samples from different areas where there's things happening or it looks like there's a higher death rate or people are sicker or whatever we're seeing, we hopefully can grab a sample from those, sequence them, and see if we can glean anything from the genetic makeup of the different viruses that are infecting different parts of the state. It'll be a long time before we have that data and some information about that, but that is something that the health department is working on.
Thank you. Sam?
Does the Department of Health have a reason for why the positive or the active case numbers have dropped in the past few weeks? Is that Do they think it's because of the mask mandate being put into place, or is there another reason?
Dr. Carson, would you care to weigh in?
Yeah, I think, I don't know if the mandates are responsible. What you can see on some sites that actually track compliance with measures, like what % of people are wearing masks, it has steadily gone up in the last several weeks in North Dakota. Another measure is how sort of out and about we are, and that can be looked at with a surrogate measure of GPS cell phone mobility. There's several sites that track that, and we have reduced our mobility. So when we wear masks more often and more frequently, and when we limit our gatherings and limit our activity and meeting with other people, those are the things that reduce exposures and reduce transmissions. And both of those have improved for whatever reasons in the last at least 2 to 3 weeks. And I think that's what's responsible for our declines in most counties now, which is very encouraging.
Thank you.
Dr. Carson, this is Jacob with KFYR. Wondering what kind of data you're going off of to say that compliance with the mandates have been going up.
So one of the places I look at regularly is the Institute for Health Metrics Evaluation at the University of Washington. They track 3 different survey groups for compliance, which is Carnegie Mellon, Facebook, and I can't remember the third one. And then GPS cell phone mobility, I don't recall the organization that collects that data, but a number of different organizations are reporting that de-identified aggregate GPS cell phone mobility, and that's been a common metric used as a surrogate for movement and interaction with other people.
Thank you. Next question, please. Lane?
This is for Dr. Carson. Do we have any updates or maybe even some theories on whether or not the virus itself might become seasonal like the flu, or if it's more of like a permanent thing that is here to stay?
Yeah, so my personal take or look at the data does suggest that there's a seasonality to it. I think we had genuine relief in North Dakota over the summer, where we had our sort of first wave in the late spring. We got some relief in the summer that I think corresponds with people being more outdoors, being able to do most of their socializing in outdoor venues a bit more separated, better ventilation. We know sunlight actually inactivates the virus. Conversely, we saw it spike in the Sun Belt states at the same time, where the extreme heat of the summer in Texas and Florida and Arizona moves people indoors and into air conditioning and so on. So I think there is a seasonality. We saw it in the southern hemisphere, peak in their winter and seem to be subsiding in their summer months. So there is a variability, I think, that corresponds with seasonality. I don't think this means it will go away in the summer. We saw it transmitted in, still, just albeit at higher or lower levels, depending on where you were geographically. Again, I don't think this stops marching through the population, either fast or slow, depending on how well we're complying with things and somewhat on the seasonality. I don't think it stops marching through the population until we are vaccinated and get somewhere around 60 to 70% immunity in the population.
Next question. Online?
I think this brings Molly back up. Thomas Simon Wilson, Trending Topics. Is there any punitive action if you refuse the vaccine? And if you refuse it first, are you able to change your mind later?
Thank you for that question. There is not punitive action if you refuse the vaccine. The state does not intend to enact any mandates regarding the COVID-19 vaccine. Under emergency use authorization, the vaccine cannot be required. So no, there might be certain employers or health systems where, if, for instance, in the future, they might say, for right now, even if you're vaccinated, you still need to wear a mask and personal protective equipment and quarantine. But in the future, I think the hope is if you're vaccinated, maybe some of that won't be needed. And so there might be some employers who might say, I'm not going to give you paid time off work if you chose not to be vaccinated and then you get COVID. Or there might be employers who say, well, if you're not going to take the vaccine, then you need to wear a mask all the time, or you need to continue wearing personal protective equipment at the hospital. I mean, I think some of that might happen, not from the state perspective, but maybe at the employee level. And if if your priority group is up for vaccination, you have the right to refuse, and later on you can definitely change your mind and get vaccinated. And I think that's understandable. For some people, it just might take a little bit for them to make their decision. So.
Another question for Molly, sorry. As North Dakota is developing its own plan for distribution, both in terms of logistics of getting the vaccine out and also prioritizing who receives the vaccine, is there anything else that you're waiting on in terms of direction at the federal level, or does the state feel like it has sort of the federal plans in place that it needs at this point?
I think the main things we need are the emergency use authorizations and the additional information about the vaccines. We need to know there are going to be certain people who cannot receive the vaccines, and so we'll need to definitely be providing that information. And then, the prioritization. ACIP so far has only prioritized officially Phase 1A, which is healthcare workers and long-term care residents. They've had discussions on the other phases, but we do really need that guidance as to who should be vaccinated in additional phases. Other things we're wondering about, I know I get the question a lot, spacing between COVID vaccine and other vaccines. Should there be a spacing? Can they be given at the same time? Spacing between having COVID and getting vaccinated. Is there a space? Is there not a space? So I think those are kind of the main things that we're waiting on from the federal government.
And just to be clear on the prioritization beyond Phase 1A, the priorities that you laid out earlier in the press conference, does that mean that those state priorities are still subject to change depending on whether the federal government comes out with more concrete recommendations on that level?
So I think Phase 1A is pretty set. What it's sounding like listening to the Advisory Committee on Immunization Practices in their recent meetings for Phase 1B, they're leaning towards other essential workers, and so police, childcare workers, teachers. That's a rather large group of people. I think in the US it's 80 million people, and so likely our ethics group and what they're starting to work on right now is prioritizing within the essential workers who of the essential workers should be first for vaccination, and then likely Phase 1C will be 65 and older and people with underlying health conditions. But beyond Phase 1A, they are definitely subject to change pending ACIP recommendations.
Jacob.
Question for Dr. Mason. Going off of the comments regarding the testing infrastructure in place, a few weeks ago, North Dakota was trending above 10,000 tests a day for the 14-day average. But since then, while positive cases have dropped, so has the number of tests. Is there any indication as to why we're not doing as much testing as we had been?
I think it's an adjustment of our strategy, and Nicole Burnell is here actually, and she's available to answer some questions maybe around our strategy, but I don't know that there's necessarily a correlation of less tests dropped our positivity rate, because it should shift equally. But I think maybe it's a little more around our strategy.
Nicole, do you have a comment?
So I also will add that in addition to our testing strategy and introducing the antigen tests across the state, over the last few days we have seen a drop in the number of tests, and I think a lot of that has to do with the holiday season, people staying home over that four-day weekend or doing traveling. So those numbers did dip down a little bit, but yesterday we had 7,500 tests scheduled just at the state lab alone. So I believe those numbers are going to start increasing again. So thank you.
So if I may, you don't think there's a smaller appetite for people getting tested?
I think there is a little bit of testing fatigue out there, but I think with the holiday seasons ramping up, a lot of people are going to want to come out and test a little bit more.
Thank you.
Well, we are at the end of our hour. I do want to thank the members of the press for attending this, and for the members of the public that are consuming this information, thank you for your attention to this as well. Take care, everyone.